Hi, morning. Hi. I've got two talks to give today, one before and one after lunch. So the first one, we're going to focus on retinal complications of high myopia and then the management of myopic choroidal neovascularization. So high myopia, everybody knows what myopia is, but high myopia is typically, if you look at the journals, there's a huge range of definitions. Some people take it as greater than -6, some -8, some -10, but most of the time I think it's fairly acceptable if a patient with -6 diopters or more of myopia can be labeled with high myopia. You can also define high myopia by the axial length, and that is greater than 26.5 millimeters. It's found in about 2% of the population, but in our local age as well as surrounding Asian context, it's not uncommon to have it reported as greater than 10%. And 60% of them would be diagnosed in childhood, and the myopia will continue to progress. There's a subset of high myopia called the pathologic myopia or degenerative myopia, where there's continued progression of changes, particularly in the area of the macula. And we'll go into that later on. And this really is the leading cause of blindness. That's why there's so many studies that we conduct in Singapore and the Singapore National Eye Centre and SERI to try to halt the progression of myopia in children. And it really contributes to legal blindness in the working population worldwide. There's slow progressive visual impairment, usually from middle age and frequently bilateral. And it's usually within the macula that the problems occur. Unfortunately, a lot of these are irreversible. Okay, but let's look at the peripheral retina first, because it's easier to clear this. We know that with myopia, there is a great association with lattice degeneration, and even as far back as journal articles from in the 80s, 90s, and earlier, people have shown that about 1/3 of myopes of -6 or more would definitely have lattice degeneration. It can be monocular or it can be binocular in about half of them. And it's usually with axial lengths of greater than 26 millimeters. And interestingly, the really high axial length, the really long eyeballs may not have as much lattice degeneration as you see in those with 26 to 27 millimeters of axial length. So sometimes you can get eyes like these, where it's really treacherous looking, where you have rows, multiple rows of lattice degeneration, and it's high risk for retinal tears and detachment. More often you get little strips of lattice degeneration such as this, and it can also be found in about 1/3 of children with high myopia. Then of course they give you the increased risk of retinal tears that require laser retinopathy to prevent events such as this, retinal detachments that then therefore require surgery, but we'll talk about retinal detachments after lunch. But myopia has been reported to occur in 1/3 to up to 80% of all non-traumatic RDs, and the risk of RD increases with the degree of myopia. -6 or more is 6 times increased risk, and every time the axial length is found to be greater than 1 mm, the hazard ratio also increases. And we found that within the SNEC audit, more than 50% of eyes with retinal detachments were myopic. So we know that myopia is a significant risk factor for retinal tears and detachments. Therefore, because of that, you get 2 peaks in the incidence as well as prevalence charts of patients who suffer from retinal detachments. There's the earlier age group, 20s to 30s, and that's predominantly due to myopia. And then there's the PVD age group, which again is associated with myopia because more often than the vitreous has abnormal adhesions to the lattice and therefore predisposed to tears. And frequently, once you have it in one eye, in these high myopes, you might see the second eye detaching soon after. Okay, and then you just treat them with buckles or vitrectomies. Okay, one of the hallmarks of degenerative myopia or pathologic myopia is the posterior staphyloма, which most of us see quite commonly is the extra bulging backwards in the posterior pole. It can come in all sorts of shapes and sizes. Sometimes it's difficult to image and assess them, but now with the more prevalent use of the swept source OCT with deeper penetration, you can see it's much better defined and the depth is much better. It's usually not seen in children. It's significantly higher in older patients compared to the younger patients. So 96.7% in those older than 50 years, 80% in those less than 50 years. So there is an element of age in the development and progression of posterior staphylomas. The incidence and height of the staphylomas worsen with age, and 3D MRIs of the globes of highly myopic eyes have shown distinctly different types and shapes. And Curtin, many years ago, actually defined 10 definitions of posterior staphylomas, depending on its location, whether it's centered on the optic disc, whether it's centered on the fovea, or whether it's decentered or even bilobed. But it's quite hard to manage a 10 definition. So more recently in 2014, Ono Matsui's group decided to have a new classification where there's another type where the outpouching is defined. Type 1, 2, 3, 4, and 5, where there's a wide macular staphyloma or a narrow. Is it near or around the optic nerve? Is it nasal or inferior? And then there's the others which are much less frequently seen. But the posterior staphyloma, therefore, is one of the root causes of problems in the myopic macula. Apart from that, it causes tilted discs with visual field defects, and therefore also patients with high myopia and tilted discs are really difficult to be evaluated in terms of glaucoma. So we know that these are high risk for normal tension glaucoma, but when you look at the nerve, you're like, I don't know, is this really an optic nerve that is just funny looking because it's with the peripapillary atrophy and the tilt, or is it really truly glaucomatous? And even if you do an OCT of the RNFL, it's going to give you some weird looking thing, right? In terms of the macula, you've got myopic macular chororetinal degeneration, predisposing to lacquer cracks and myopic CNVs, and then there's the tractional aspects of the myopic macular schisis, holes, and detachments. And really, a lot of this was more defined more recently because of OCT. Previously, all high myopes, you just see the tessellated fundus, the degenerated macula, and you just said myopic macular degeneration. But with OCT, we can define and see a lot more. And you can even look at it on the on-fast scans, so you can see the areas of degeneration, and then you can correlate it later on. I'll show you more. So the effect of the posterior staphyloma, there's the tractional component as well as the degenerative component. The tractional component, so there's progressive bulging backwards of the staphyloma, but your ILM and the retina remains intact. So the retina starts to become split in its layers, and that's how you end up with a myopic tractional maculopathy or macular schisis that can progress all the way to macular holes and macular hole detachments. And then there's the degenerative aspect. Because of continued progressive outpouching, the choroid becomes stretched, becomes thinner, there's risk of rupture of Brooks membrane, and therefore you get the other aspects such as atrophy and choroidal neovascularization. So this OCT, you can see quite nicely how the ILM and the posterior staphyloma stretches the retina. And here you can see that here there's thinning of the choroid is really thin here and absent in these areas where there is degeneration. So let's look at high myopia and the macula. First, myopic traction maculopathy. It's seen in up to 1/3 of eyes with pathologic myopia, and like I said earlier, it's really because of the advent of OCT, it's really an OCT-based diagnosis. And it's due to the tractional forces from the surface of the retina, the vitreous cortex, and the posterior staphyloma. It can occur asymmetrically, so an individual, say bilaterally -11, but the right eye you see has got schisis, but the left eye looks fairly decent. It can also occur in eyes with not such high myopia, such as the right eye of this patient who's only 4 diopters short-sighted, but has significant schitic changes compared to the left side. So in 2013, Shimada was the one that decided to help us all classify the different stages of schisis. S0, where there is no schisis, you can have ERMs and all, but there's actually not much splitting of the retinal layers. S1, where it's extrafoveal, so you can see here, it's just in this temporal area. S2, where the fovea starts to become involved. S3, the fovea and more extensive, but not the entire macula is involved. And S4, when the entire macula has become a sponge kind of effect. So the S4 eyes, as expected, will have the poorest presenting vision, the thickest central retinal thickness, and are more likely to have problems in terms of vision because photoreceptor detachment, ellipsoid zone disruption, as well as if it continues to pull, you do get the retinal detachment. And in our experience, we found that these eyes, the average age, 60-something, axial length, you can see that they're pretty long, around 30 millimeters, and on average about 12 diopters of myopia. At least 1/4 at presentation would have photoreceptor detachment. About 1/3, the ellipsoid zone disruption, so the outer retina is quite significantly disrupted. Several of them would have either a partial thickness macular hole or even a full thickness macular hole at presentation. But when we monitored these eyes for up to 3 years, vision remained stable in about 3/4 of them. And we found that if the central retinal thickness remained stable, vision was unlikely to deteriorate. So you look at this patient 2, it's got really thick central retinal thickness, but the vision remained stable for the course of 41 months. So you may not have to do anything because there is no progression. But there is progression, therefore, in about 1/4 to 1/3 of eyes, either because of loss of vision or and that's because either, you can see that in this patient 3, the schisis progressed with neurosensory detachment. And then in this one, it was S3 because it was only this side of the macula. And then by the end of 2.5 years, the whole macula had become involved with the schisis. And that's when you have to consider surgical intervention to prevent further deterioration of vision. So when you see an eye with myopic schisis, you don't have to really jump into the eye and offer surgery because, like I said, 3/4 remain stable. And when do we offer surgery? When there's definitely impact on vision. If it remains stable, largely it's due to the fovea not being detached. If the fovea remains nice and like this, good vision can be preserved even in S4 stage, but there is always a risk that the ILM can continue to pull or the posterior staphyloma can continue to extend backwards, and then you may end up with hole formation or neurosensory detachment. So when we looked at our eyes that needed surgical intervention, again, you can see it's similar to the first study that we did. Refractive error on average is -12, axial length is again almost 30 millimeters. We found that majority of the eyes that needed surgery were in S4, some S3, some S2. S2 because it involves the fovea. So if there's progressive thickening of the foveal region, you may have to do surgery. And some of them were associated with macular holes and ILM disruptions. So of course you need to do a vitrectomy and you have to relieve the tension by peeling the ILM. There's always a risk of inducing a hole during the surgery, and repeat surgeries may sometimes be required to patch holes. When you look at vision, the vision continues to improve up to 12 months because while, like I tell patients, while I can peel the ILM, I can't make the sponginess go away immediately, and that can take up to 1 year to go. So the visual recovery correlates with the anatomical recovery. So it continues to improve as the sponginess of the retina reduces. Sorry. Okay, so up to 12 months. So this is an eye. You can see that we did surgery because of foveal detachment, and the patient was symptomatic for about 6 months. After surgery, you may peel off there's no more tension on the surface of the retina, but the neurosensory detachment as well as the schisis needs time to settle. 3 months, you can see that the schisis is less thick, but the neurosensory detachment is still intact. And by one year, it's more or less flattened out and vision has improved to 618. So you actually have to sit tight on these patients. This is another eye. Again, it took 1 year for the schisis from a full S4, the entire macula was involved, to at 1 year recover to 6.9 for the foveal contour to recover. But sometimes, no matter what you do, there's too much atrophy. Retina may look flat, but you can see that the layers did not recover, and so therefore the vision remained at 6/120. So the foveal detachment generally resolved at about 3 to 4 months after surgery. The schisis about 6 months. The ellipsoid zone also about 6 months, and all this would therefore have impact on visual recovery. If there is foveal detachment, dome-shaped sclera, or poor VA pre-op presentation, you're more likely to have significant improvement. There was no significant association for duration, axial length, refractive error, or whether you use gas or what type of gas you use. Interestingly, if you look at the fellow eyes of these patients, they all have problems too, because very often these are symmetrical. They would have posterior staphyloma, they would have some tractional component, whether it's a VMT or schisis or macular hole, like this. So the macular hole is really the end stage of the traction maculopathy in myopia. And when we looked at our series of 114 patients, again similarly -10 diopters with long axial lengths, and very often, even though you can get the retina to flatten out, the macular hole doesn't fully close up in a lot of patients. And having the OCT helps you look at recovery. So while it flattens out, but you can see there's disruption at the fovea, so the vision will definitely be limited by, the recovery of vision will be limited by this disruption. And of course, it can also happen in fellow eyes. So the first eye had schisis surgery, vision recovered to 6.9. Sometime later, the left eye develops a mac hole with detachment, and then you need to do surgery for the other eye as well. Having OCT also helps you prognosticate an eye like this. Really no point doing surgery because there's nothing left inside the retina. Yeah, so no matter what you do for this eye, the vision will still remain hand movement. Okay, so let's move now to the degenerative maculopathy associated with high myopia. So this is very common, right? An image such as this that we see in our clinics, tessellated fundus, some patchy loss of the choroid with the underlying sclera seen through peripapillary atrophy as well. And again, more progressive as the time goes on, especially if the patients are a little bit older. So you can actually nowadays classify the extent of myopic macular degeneration. Avila did this one, M0, M1, when there's choroidal pallor and tessellation because the choroid starts to become thinner and underlying sclera starts to come through. When there's a posterior staphyloma, it becomes M2. When you start to see lacquer cracks, it's M3. And then when there's focal areas of chororetinal atrophy, it's M4. And then when there's large areas of atrophy with deep choroidal atrophy, means you actually really see the sclera coming forwards now, that's M5. Then, about 3 years ago, there was a big work group led by Kyoko Ono Matsu. They run a very huge high myopia clinic in Tokyo. So there's a consortium of 8 different people, including Singapore representation. And the META-PM international classification was established from category 0 to category 4, where 0, there's no macular lesions. Then it goes into tessellation only, diffuse chororetinal atrophy, patchy atrophy, which is, you see little circular areas of the sclera, and then macular atrophy. There are 3 features that are called plus signs, which would increase the risk of further visual loss: lacquer cracks, choroidal neovascularization, and Fuchs spot. So this updated classification, so you would then therefore say patchy atrophy associated with lacquer crack, or patchy atrophy associated with diffuse atrophy, or it can be patchy atrophy associated with choroidal neovascularization. And because of this, this flowchart was created by Hayashi, and all links, right? Because once you have a tessellated fundus, it increases your risk to developing chororetinal atrophy, which then predisposes to lacquer cracks, CNV, as well as patchy atrophy. The ultimate is they all end up with macular atrophy. And at this point in time, we're still not able to prevent the progression to macular atrophy. When you looked at over 12 years, about 13% of tessellated fundus would show progression to whether it's patchy or diffuse or macular atrophy. Significantly, 69% would develop with lacquer cracks, would show progression, and 70% with patchy atrophy. But 90% with CNV would definitely develop macular atrophy. So if you, later on I'll show you images of CNV, you may treat the CNV. CNV is nice and quiet, but as you follow the patient up year after year, the surrounding ring of atrophy that just develops around the old CNV. The presence of the posterior staphyloma is a significant contributor to all these changes. So you can see this eye over a period of 16 years. First, it was just tessellation, then the patchy, the bit of diffuse atrophy here, then the patchy areas. These patchy areas join up, and eventually it's a diffuse area of macular atrophy where there's literally no more retina or choroid there, it's just the sclera showing through. So in the 10-year follow-up, 90% at 40 to 49 years still have 20, 40 or better, but when they're more than 60 years old, less than 40% are 20, 40 or better after 10 years, and more than 50% would have lost at least 2 lines of Snellen vision. And 40% would show progression of their myopic maculopathy and deterioration in vision. So it's not great to have, once you label somebody with myopic macular degeneration, it's not a great diagnosis to give because over time they will get worse. And it's all contributed by age, severity of myopia, the axial length, and the extent and how bad the posterior staphyloma is. Okay, so this was the one I showed you earlier. So this shows you now, you can see here how thin the choroid is under the fovea, and around the fovea there's structure of Brooks membrane, and there's complete loss here of the outer retina as well as the choroid, and that is why you get all these areas of atrophy and loss of vision. Lacquer cracks, you can see it nicely on the OCT as well. Okay, right across the macula, yellowish thick, linear, it can be horizontal, vertical, it can be stellate, and it can crisscross, and it can therefore predispose to hemorrhages and CNVs. ICG is widely accepted as the best method for detection of a lacquer crack. You see linear hypofluorescence in this example. All these lines are lacquer cracks that can radiate from the disc at the papillomacular bundle area. It can cut through the macula. It cuts through the macula, then the patient would have persistent metamorphopsia. Fluorescein angiography is slightly less sensitive because of all the leakage and RP atrophy windows that would disrupt this. And you can see from also using the infrared, you can see lacquer cracks. OCT, you can see disruptions. And fluorescein, the fundus autofluorescence, you can also make up the areas of linear hypoautofluorescence, but low sensitivity. And that having a lacquer crack also increases your risk because of the rupture in the Brooks membrane. The choroidal neovascularization can form easily, and the new vessels will insinuate through the areas of cracks. So it's one of the most vision-threatening complications of myopia. About 1/3 of patients with myopic CNV will develop CNV in the second eye within 8 years of diagnosis of their first eye. And this results in significant reduction in quality of life. Very often these patients are fairly young and still part of the working community. About 5 to 11% would have pathologic myopia. Myopic CNV can also occur in eyes with low myopia. And it's the second commonest cause of CNV, but the commonest cause for those under 50 years. Somehow it affects females more than the males. Once you have these three risk factors, the incidence increases: lacquer cracks, patchy atrophy, as well as diffuse atrophy. Okay, it's usually small. Sometimes it can be quite hard to see, so sometimes we put a green filter to try to check whether there really is or isn't a bleed in the macula. It can arise like next to a lacquer crack like this eye. You can see there's a very clear lacquer crack there, and the fluorescein angiogram shows the leakage right next to it. But sometimes in such an eye where there's already diffuse atrophy, it can be difficult to see clinically, and the FA, you can see it, the lighting up the hot spot there. So you have to suspect it in eyes with pathologic myopia. Look at their refractive error, but you have to be careful, especially nowadays with cataract surgery. A lot of patients don't tell you what their predisposing or underlying levels of myopia is. You can also tell from the axial length. But more oftenly, when you look at the eye, you can see the typical myopic macular features like the lacquer cracks and atrophy. And of course, nowadays, OCT is extremely useful. You see hyperreflective mounts and coexisting pathology. Sometimes you're lucky, you see a very obvious bleed in CNV such as this. And OCT, you see a giant mountain. But sometimes you see, you're not sure, is it just the choroidal vessels just showing through? Is there a bleed or not? But you do the OCT and quite clearly you can see that there is an area of disruption with hemorrhagic accumulation. So the OCT is extremely useful. It shows you the thin choroid, and the staphyloma is often evident. The myopic CNV doesn't look as fierce as age-related type of CNV. There's usually less subretinal fluid, and you see a lot of hyperreflective material that gradually becomes more and more defined with treatment as it scars up. You have to do dense volume scans because it can be small and early, and if you don't do enough cuts through the macula, you may miss it on the OCT. Fluorescein angiography is of course the gold standard. 80% or more of the time you will find a nice classic CNV. Leakage, again, less fierce compared to age-related type of CNV, and it helps you with your location and prognostication because you will tell whether it's extrafoveal, foveal, and then whether there's fibrotic components, scarring, and extent of the lesion. So the first eye on top, you can see this one should do very well with treatment, and the bottom eye, while you aim to quieten down the eye, you do not tell the patient you're going to improve the vision because very likely you're going to have a massive scar even after you treat the eye. OCT and FA will help you tell the difference between, is it a hemorrhage is it because of a CNV, or is it just a rupture because of a fresh lacquer crack? Yeah, so like this one, you can see it heals up nicely, there's nothing there, so it's just a lacquer crack. And when we acquired the swept source OCT, the on-fast scan, you can make out the nice network of a CNV, on a horizontal slab at the level of just under the neurosensory retina. And nowadays we use OCT angiography. The myopic CNV is one of the best diagnosis to follow up on the OCT angiography because most of the time there's not that much fluid and exudation to disrupt the scan. You see nice classic networks. So what I usually do nowadays is to just do the FFA to confirm diagnosis, but to follow up with OCTA. So this is another example. You can see it nicely, the whole network there, and you can do all sorts of tricks on the OCTA. There are various machines available. You can look at perfusion flow and activity through the CNV network. Okay, what happens to a myopic CNV? There's first the active phase, so that's the hemorrhagic and the swollen phase. Patient presents with sudden central scotoma, sudden central metamorphopsia. And then there's a scarring phase, and then you end up with the atrophic phase. So the aim of treatment is you want to limit the size of the scar phase. At this point in time, we can't really do anything to prevent atrophy. Yeah, so you can see that over time it would become one huge area of bare sclera. It can be tricky because there will be very often eyes with concomitant pathology. You can have an eye with myopic schisis and then a CNV develops, right? So it can then trick you into thinking that, oh, it's just progression of the schisis, but actually there's an underlying CNV going on. Sometimes there's a ERM that distorts the anatomy, so doing an FFA or OCTA will help confirm the diagnosis. Sometimes, this is just a rare case of macular detachment after giving intravitreal Avastin. High myopes, or even myopes, especially females, would be at risk of PICs, punctate inner choroidopathy. You have to be aware of that. The OCT looks slightly different. These inflammatory type CNVs have more, described to be on the OCT, more horn-shaped, more pointy type of infiltrating lesions. And then you may have to treat with a little bit of steroids or anti-inflammatory agents, such as this. This one's more obvious. You can see that all these areas of PIC, and you can over first the active phase and then it quietens down. And this is another example. Sometimes you can get a serous detachment over the dome-shaped macula. If you OCT scan a lot of the high myopes, sometimes you might find eyes with a dome-shaped sclera, and that can actually, we're not sure why, predispose to serous detachments. And then you wonder, okay, is that a CSCR or is there an underlying active CNV? Don't forget, these are Asian patients, so there's always a risk of polyps. Polyps can occur at the edge of the staphyloma. It could also be a secondary CNV, right, from other causes. And retinal detachments can occur because of breaks along the staphylomatous edges. Schisis, like I told you, can cause disruptions to the anatomy and kind of, make us think a little bit harder. But the OCT guides us really in anti-VEGF therapy now. Like I said, the aim is to limit the size of the scar, reduce the central scotoma, and improve vision as quickly as possible. We follow up with OCT and OCTA. So you can see this eye with the CNV. After 1 week, it's starting to consolidate. At 1 month, it's more defined, and at 3 months, you see this very nice, well-defined, encapsulated knuckle there to tell you that, okay, now we know this eye is quiet. If you see fluffy edges to it, then you know it's still an active lesion, and you continue with treatment. There's an eye -9, 645 at presentation. You can see the CNV and the underlying lacquer cracks. After 1 lucentis, it looks, wow, really nice. So, myopic CNVs also do not generally require as many rounds of treatment as age-related or even idiopathic CNVs. Yeah, so even though we tell them 3 KIV more, very often you can stop at 2 or 3 and monitor them. But of course, if you have a bigger lesion like this, then you have to treat it more, and no matter what you do, even though you end up with a nice defined scar there, vision will not get better than 660. Okay, these are more examples. And then OCTA and geography at the time of diagnosis, and after intravitreal injection, you can see the regression quite nicely. But what we really cannot prevent is the macular atrophy, or the stage 4, the end-stage myopic macular degeneration. It's a well-defined round chororetinal atrophic lesion, usually grayish or white because it's just a bare sclera showing through, generally focused centrally on the fovea and often around a regressed CNV. And we're still not sure what the mechanisms are. So when you have a vision like this, if it's bilateral, then very often you only can get the patient to see the low vision specialist and guide the patient along with low visual aids. So myopic macular atrophy is irreversible, and sometimes if you have a good low vision specialist, you may be able to train the patient to use a new fixation point outside the area of the central scotoma. So multimodal imaging provides valuable information for the diagnosis and monitoring of myopic CNV. Characteristic signs can be seen to indicate the different stages and therefore help you decide how you want to treat, how long you want to treat. And imaging is important to differentiate the Myopic CNV from other differential diagnoses. And like I said, don't forget that it can occur concurrently with other features of pathologic myopia, such as this eye where there is schisis as well. Okay, so you need to also educate the patients with high myopia that they are high risk. Very often they just hear about floaters, and panic when they see floaters, but actually they do get all sorts of central vision problems, and they should present as early as possible to be treated and prevent visual loss. Thank you. Any questions?
Morning, you did mention
yes.
Cannot prevent the myopic maculopathy changes, but do you think glaucoma can aggravate the myopic degeneration?
I don't think it aggravates. It's usually, it very often occurs together. So then it just makes things a bit worse for the patient because they get the central atrophy, and then you have the glaucomatous visual field constriction, so it's a double whammy. So I think all these high myopes, we just have to monitor them very carefully. And it's tricky, like I told you earlier, you can't just look at the optic nerve like in other people who don't have all these funny looking nerves because of the high myopia. So you have to do other things like visual field monitoring and all.
The IOP in the higher side,
very often the high myopes have normal tension glaucoma. The IOP is 16. Yeah, so you can't just say, I follow by IOP. Very often it's normal tension.
In children, we do ask them to prescribe auto care or atropine to prevent myopic progression. Does it work in adults?
No, the atropine doesn't, we don't give it to adults. Most of the time, we take it as stabilization of the refractive error by around 20, 21 years old. Most of the time, it doesn't progress. It's only in people with these horrible looking staphylomas that may continue to progress and therefore end up with all these complications. But atropine doesn't do anything to that, I don't think. There are some studies going on looking at scleral rigidity strengthening. There are some people who do scleral imbrication to strengthen the retina. Some people do macular buckle, some people do scleral cross-linking, but a lot of it is anecdotal, just like one or two cases reported, not proven to protect the posterior staphyloma progression. Yes.
What is your surgical approach for myopic retinal maculopathy? And have you found any usefulness of intraoperative integrated OCT in managing such cases?
Yeah, I think you can, it would help looking at the intra-op OCT that you've peeled the ILM properly, and to look at the integrity of the macula, especially whether there's a macular hole or not. Sometimes in these eyes, it's difficult to do because of poor contrast, because the underlying choroid is thin, you may not, and the retina is thickened and spongy or even detached in the center. So the OCT can guide you, but of course not everybody can afford intra-op OCT. So it's easier to probably use a stain to help you look at areas where you've peeled and where you've not peeled. Because previously when we used to do surgery without stains, then sometimes it's a bit tricky to say, oh, have I peeled this area or not? So I routinely use the membrane blue dual now for these eyes.
Do you put gas in all of them at the end of surgery?
No, I generally don't unless I suspect that there's a hole or inadvertently you cause the hole, because these retinas are very thin. And I think that we found that in our experience, the gas doesn't make much difference in making the neurosensory detachment go away faster. That really needs time. And it's shown that up to 6 months to a year for that to happen. So the gas doesn't serve much purpose there.
Any more questions?
What if due to the staphyloма, even if you do the ILM peeling, if you remove the epiretinal membrane for traction macular PNV, retina doesn't go back, it doesn't conform to the staphyloma over a period of time. Do you have any other options that you do another surgery?
Most of the time, if the ILM is relieved, most of the time it does go back. Yeah. I mean, like I said, we've tried to look at acquiring the macular buckles, but having spoken to colleagues in Japan and all, they all moved away from doing the macular buckles because maintaining the position of the buckle is very difficult. You're just hooking it there and it would move with eye movement, and very often it slips, so it doesn't really help in the long term. And because also it's there, it can also erode on the sclera, and these high myopes have got very thin scleras as well.
Whether floaters have associated with longer duration working in the monitor. I haven't been happy to about that. That's the first question. And then the second one, regarding floaters, is there any medication we can use? When I see the fundus, I didn't see any retinal tear, and also I didn't see any complete PVD. So I told the patient, right now we have no evidence that could remove the floater. So is there any modalities or?
I generally don't do anything for floaters. These are already high-risk eyes, high myopes and all. I know a lot of people, some people would offer floaterectomy. I wouldn't do that because, like I said, these are high myope eyes, and then yet vitreolysis, I know some people offer that. Again, these are high-risk eyes. Any disruption to the vitreous and the hyaloid can also trigger off a retinal detachment. So I just tell patients just have to live with it.
So there's association between the incidence of the floaters with the monitor?
Not that I know of.
No.
Yeah.
Thank you for your talk. For those myopic fovea species, when you treatment with surgical interventions, so do you always peel all the eye off, or have you ever tried fovea sparing and peeling to prevent the?
So if it's just pure schisis with no MAC hole or no lamellar defect, it's okay. I find it's alright to peel the entire ILM off. But sometimes in these high myopes, it just stuck there, so you don't peel. I would just trim and leave it at the fovea as long as there's no traction there. If there's a MAC hole or a lamellar defect, then sometimes I leave a little tuft and just do the fovea sparing, because you just pull a little bit, it just pops, the whole thing become a hole, and it just makes it very much more difficult to recover. So you just have to watch the anatomy, and you can see the traction. Sometimes as you peel, you can see the stria coming, and it's stuck there. Then I would just not overdo it. As long as there's no traction, then I just trim it down and just leave a tuft at the fovea. Okay, I think we're going to break for lunch, and then we'll come back for the next talk at what time? 1:15. 1:15, right? Okay, 1:15. Thank you.